Okay, class. So next we'll be moving into assessment of pulse rate and heart rate. So kind of like this little cartoon here. So I don't do too much traditional exercise, but I make sure to get my heart rate up by freaking out at the office on a regular basis. And of course, Nancy and Ann Wilson, who are the leaders of the band Heart. All right. So heart rate and mortality, again, heart rate's super important to assess. I think we often forget its importance when we're making our assessment of patients, but a higher resting heart rate is associated or is independently associated with increased risk of all-cause of cardiovascular mortality. So it's a pretty strong prognostic tool and diagnostic tool in some respects. And the risk of mortality increases by every 9%, by 9%, 8% respectively for all cause and cardiovascular mortality for every 10 beats per minute above every 10 beat per minute increase above resting heart rates. So especially if your heart rates at rest are above 90. Now, generally, we say heart rate for an adult should be between 60 and 100. Obviously, the lower you can go on the end of normal, the better. But it's definitely a bit of a concern if you're chronically elevated, right? You're in the hundreds, right? That's never a normal thing. Now, there are, again, some patients that are bradycardic, right? So their heart rate's a little bit slower than normal. So they're below 60 beats per minute. And we'll get into some situations where that would be completely normal or expected. Like if someone's taking certain medications or is a highly trained athlete, for example. And generally, bradycardia, we go by symptoms. Like there really isn't, an absolute threshold for that. Generally, if someone has a low heart rate, and they have no symptoms, they're not lightheaded, they're not dizzy, like it's something that's obviously abnormal, but we don't really, view it too concerning if they have no symptoms. Now, this is that plot again, looking at higher resting heart rate. Again, the higher you go, like your risk of mortality goes up. Again, in this fashion here, and we see the same thing for cardiovascular mortality. Now, normal values, again, in someone who's an adult, or really anyone above 10 years, the normal range for your heart rate is going to be 60 to 100 beats per minute. Now, again, in a well-trained athlete, it's not abnormal to see their heart rate below 60, between 40 and 60. I think Lance Armstrong, I think his is actually delved a little bit below even 40. So it's in someone who's asymptomatic, heart rate is as low as you can go. I would be concerned if I was working with an older patient, someone who's not trained, or someone who had a heart rate that had been in the 60s, 70s, a normal range, and then suddenly went below. So that's the value of consistently measuring vitals to see if there's been a discrepancy acutely. But again, we go by symptoms for bradycardia generally. In younger, patients or in children below 10 years of age, their heart rate ranges are going to be a little bit higher. That's because the heart is still sort of growing as you're a kid, and it's smaller, like when you're a child, like compared to an adult heart. So again, going back to stroke or to cardiac output, right? If your stroke volume is smaller, like they are as a kid, with a pediatric heart or a heart of a child, to get the same amount of cardiac output, the heart rate has to be a little bit higher. So in children, 79, 70 to 110. For newborns, it can be as high as 190 in some respects. So again, the values decrease as we age for normal ranges, and as our heart gets to its adult size. And then again, for adults, it's 60 to 100. Anyone above 100, we would call tachycardic. So that would be, write that out, tachycardia. My little tachycardia. Tachycardia. I'm getting tachycardia. It's a fast heart. And then anyone below 60, we call that bradycardia. And that's anyone who's 60 or below 60. This would be anyone above 100. Okay. Now, the assess pulse rate, right? So key thing to bear in mind when we're assessing heart rate using a peripheral pulse, it is technically called the pulse rate because we're not actually assessing the heart. we're assessing the pressure wave that the heart has produced, downstream in the arterial system, which can or slightly be different than what the actual heart rate is. Maybe if there's a blockage or spasm or something that impedes the propagation of that pressure wave, you might not actually capture the exact heart rate. Now, but you'll see it used interchangeably, pulse rate, heart rate. Just to bear in mind, there is a slight difference, and if you're measuring it at a peripheral pulse, it may not exactly be the same. It'll be pretty close. Now, when we measure heart rate using a peripheral pulse to give us that pulse rate, we can only reliably, right, with a reasonable reliability, assess it at the carotid artery or the radial artery. So all those other locations that we looked at pulse amplitude, such as the popliteal, dorsalis pedis, like you can't reasonably or reliably assess pulse rate there, just because, as we talked about in those examples, a lot of people that may not even have it, or if they have other issues with body habitus or edema, might not be able to find it. The carotid artery, the radial artery are superficial. They're very superficial, so it's very easy to find. So you're going to use those locations. When we're assessing heart rate, you want to do this for at least 15 seconds, during exercise. At rest, you really should be assessing for at least 30 seconds, up to 60 seconds. And again, we're counting how many beats we feel in that interval. So for example, if we feel, while palpating, 35, taps in that 30-second interval for counting for 30 seconds, that would be a heart rate of 70 beats per minute, because we've, just multiplied that interval times 2. I recommend measuring the time using your watch. Obviously, things are getting different now with technology. I really strongly recommend to not use your cell phone, just because some patients may view that differently. Maybe make you appear that you're distracted or not focusing on their care. Just be mindful of it. You should always have a wristwatch on when you're in the clinic anyway. It's just a good thing just to have on you. You'll use a wristwatch with a stopwatch, a second hand, pretty often. Now, the reason why it's not recommended to measure heart rate at rest less than 30 seconds, except maybe in an emergent situation, is that below 30 seconds, you may miss arrhythmia. So someone may have a beat that drops out. The shorter the window of time that we assess heart rate, the more inaccurate our measurements get, and the shorter the window we have to actually capture what may be going on. So just be mindful of that. Like, you can get a pretty good estimation, but it's less accurate with measuring over a shorter period of time. Now, say you did notice some, funky beats going on at these peripheral pulses, or if you really wanted to get a direct measurement of heart rate, you can assess the apical pulse, which is auscultating at the 4th or 5th interclavicle space, the midclavicular line. And you'll learn more about auscultation later on in your cardiopulmonary coursework, but this is the most accurate assessment of heart rate without using an ECG or a polar device, which is going to capture the electrical activity produced, which is a direct assessment, versus, again, pulse rate, which is sort of indirect because we're assessing the pressure produced by the heart, which could be impeded for a lot of different reasons. So, if you want to get a direct assessment of heart rate, you can just listen to it. So that's the apical pulse. If you see that reference, you're auscultating and listening to the heartbeat, or really the valves closing, but you'll learn more about that later. And then when we're assessing pulse rate, we want to be assessing for the rhythmicity and regularity of that pulse rate, right? Are the beats in succession, right? Are they occurring in a regular fashion? Normally our heart rate should go in a regular beat. It should be, beat, 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 beat. That's actually kind of fast, but it should be a consistent interval of time, right? In a patient maybe with an arrhythmia, you may have an irregularity in there. So in some instances, you may have this pattern where it's a normal beat, normal beat, normal beat, pause, normal beat, normal beat, normal beat, pause. So there's an irregularity. There's a prolongation in the interval of time, or a shortened interval of time for Either way, there's an irregularity that occurs in a regular fashion. So again, a regularly occurring rhythm would be the beats occur in a consistent pattern, beat per beat per beat. In a regularly irregular rhythm, there would be an irregularity, but it would happen in a consistent manner, right? The irregularity happens regularly. Now, there are some situations where a patient may have an irregularity that happens in a completely irregular fashion. So it'd be beat, 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 all over the place. And there are certain conditions like AFib and other things you'll learn about where that happens. But that's a different presentation. So we've got regular rhythms where again it's beat, 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 normal. And then we've got regularly irregular rhythms. So there's an irregularity, but it's happening in a consistent or a regular fashion. So it would be beat, 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 beat. So there's a prolonged pause, but it happens consistently every three beats. And then in the irregular rhythm, it would be all over the place. Okay. Now, if you ever suspect someone has an arrhythmia, you could, from feeling it on the pulse, follow up with an apical heart rate assessment. Can't diagnose anything, but you can get, be suspicious of it, refer it to the primary, and they'll get an ECG. So we can't really diagnose any arrhythmias without an ECG, but we can definitely suspect a patient. And it's a good thing to report if it's a new finding. So have you guys practice that on each other, and then we'll move into blood pressure, and then we'll kind of wrap up here.